Well, good evening, everyone. My name is Jason Savage from the Cleveland Clinic. I want to thank Trey Crawford and Mike Gerling for the opportunity to participate in this ICL. I also want to thank everyone on the CSRS program committee for making this virtual experience possible. So I'm going to talk a little bit about avoiding iatrogenic cervical deformities and particularly focus on laminoplasty. These are my disclosures, none of which are relevant to the contents of this talk. I'm sure everyone tuned into this ICL is very familiar with the laminoplasty procedure. I could tell you it's one of my favorite operations and I think one of the more successful operations, but there are a lot of things you need to consider in terms of deciding who's a good candidate for the laminoplasty. Laminoplasty is a motion-preserving procedure that allows indirect and direct decompression of the spinal canal. It was popularized in Japan for the treatment of OPLL, but is really now widely used and adopted worldwide for the treatment of CSM. There are some relative contraindications, and there is a little bit of controversy around some of these, but the relative contraindications is kyphosis, segmental instability, and neck pain. So in terms of prevention of iatrogenic deformity from a laminoplasty, these are really the three things I think we need to consider. I think we need to consider the preoperative alignment. I think we need to have some surgical considerations in terms of technique. And I think you have to think about post-op care. And really what we're trying to avoid and prevent is something like this. So let's start with a case. This is a 68-year-old male with worsening CSM. If you look at his lateral x-ray, he's got spondylosis. His overall alignment is about neutral. His C2 to C7 alignment is basically 0. And his C2 to C7 SVA is about 3.5 centimeters. If you look at his MRI here, he's got pretty significant cord compression from C3, C4 through C6, C7. So in terms of preoperative alignment considerations, these are the three things I think we need to focus on. How much kyphosis is too much? Does sagittal balance, regional and global balance matter? And what about T1 slope? I think most of us would agree that the laminoplasty procedure is ideal in patients with multi-level CSM with no significant axial neck pain, neutral to lordotic alignment, and no segmental instability. With that said, several authors have reported good results with up to 10 to 13 degrees of kyphosis. But just like anything else in spine, there's some conflicting data, and other studies have shown worsening outcomes with JOA scores with any degree of kyphosis after the laminoplasty procedure. So I think one of the most important things to consider for this particular talk is, who is at risk of developing postoperative kyphosis after the laminoplasty? This is a nice study published in 2016 looking at regional sagittal alignment and trying to predict postoperative kyphosis. A retrospective review of 176 patients with CSM with no pre-op kyphosis. Post-op kyphosis developed in 9 patients, or 5.2% of this cohort. The recovery rate of the JOA score was inferior in the kyphosis group, and they found that regional alignment, as measured by the center of gravity line to C7 SVA, age, and an increased C7 slope were risk factors for developing post-op kyphosis. They looked at some threshold values, and they found that a regional alignment, or SVA, of greater than 4.2 centimeters, or an age of greater than 75, puts you at risk for developing kyphosis. And this is just looking at the data a little bit further. The average age in the kyphosis group was 79. The average age in the non-kyphotic group was 68. If you look at the SVA, it's 5.4 centimeters in the patient group that developed kyphosis versus 1.8 centimeters, and the higher C7 slope in the group that developed kyphosis. This is another study kind of looking at a similar thing, retrospective review of 94 patients with CSM, no pre-op kyphosis. Post-op kyphosis developed in 21, or 10.8% of patients. Again, the recovery of the JOA was inferior in patients who developed kyphosis postoperatively. And they found that the risk factors for kyphosis were an elevated C2 to C7 SVA, if the C3 lamina was included in the laminoplasty procedure, and or if there was disruption of the facet joints. So what about T1 slope? I think a lot of us are focusing more on T1 slope now, and kind of getting a better understanding of how that impacts postoperative alignment in fusion and laminoplasty procedures. This is a retrospective review of 51 patients with CSM, French door laminoplasty, and they found that a higher pre-op T1 slope was associated with a significantly increased odds ratio for postoperative kyphotic alignment changes. They broke the groups into a high pre-op T1 slope and a low pre-op T1 slope. The average high pre-op T1 slope was 30 degrees, and for the lower group was 22 degrees. And this group postulated that basically for patients with a higher T1 slope, they need more cervical lordosis to maintain their over-regional alignment. And after a laminoplasty procedure, even though it's a motion-preserving and posterior tension band preserving procedure, they feel like patients are unable to maintain the amount of lordosis needed to maintain their over-regional alignment, whereas the low T1 slope which needs less of a cervical lordosis, were able to be maintained. Again, this is just one postulation from this group of why the high T1 slope groups tended to fall into kyphosis compared to the low T1 slope group. What about overall alignment and sagittal balance? Well, this is one study that looked at 84 patients undergoing an open door laminoplasty. They actually had an incidence of postoperative kyphosis of 25% post-op, and they found that a preoperative C7 SVA in their pelvic incidence lumbar lordosis mismatch was actually smaller in the group that developed kyphosis. And they summarized and said that if you have a smaller C7 SVA and you have hyperlordosis pre-op, you may be at an increased risk of developing kyphosis after laminoplasty. I think there's a lot we still need to learn about looking at overall sagittal profiles and balance in terms of kind of implications on the laminoplasty procedure, but I think that's something a lot of us are starting to pay more attention to, and I'm sure there's gonna be a lot of data coming out in the next few years. So in terms of preoperative alignment considerations, I think laminoplasty is a good option for multi-level CSM. My personal practice, I'm looking at neutral to lordotic patients, Kalon negative patients, and things I'm starting to worry about or think more about are, increased C2 to C7 SVAs. Maybe not doing these on patients with a C2 to C7 SVA greater than 3 to 4 centimeters. Look for high T1 slopes, look for focal kyphosis, and I think we're going to learn a lot more about the overall sagittal balance and profile of patients undergoing laminoplasty procedures. So what about surgical considerations? Should we lift C3? Should we dome C3? Should we do a laminectomy at C3? I think it's really important to do a meticulous dissection and closure in these patients to help prevent kind of patients falling into kyphosis. And I think you need to do an aggressive post-op PT program to really kind of maximize the extension kind of these patients and their extensor muscles pretty quickly post-op. So where should we start the laminoplasty? This is a nice study by Keith Michaels' group, John Reeves' group out of Emory. Retrospective review of 65 patients with CSM treated with open door laminoplasty. Primary outcome was change in lordosis, and they found a significant loss of lordosis if C3 was included in the laminoplasty, 9 degrees compared to 3 degrees. I think a lot of us have been talking more and more lately about doing either a dome C3 laminectomy in our laminoplasty or doing a complete C3 laminectomy with really the sole intention of trying to avoid disrupting the muscle attachments onto C2 or C7. There's another study just looking at postoperative neck pain, Group A, C4 to C6 laminoplasty with a C3 laminectomy versus Group B with a C3 laminoplasty included in the laminoplasty procedure. And they found that there was significantly increased neck pain if C3 was included in the laminoplasty procedure. And this is just a nice review article by Dan Rue's group looking at the importance of preserving the muscle attachments of C2 and C7 in the laminoplasty. So going back to the case example, this patient ended up having a C4 to C6 laminoplasty with a partial C3 laminectomy, and I'll tell you that tends to be my go-to procedure for the laminoplasty. Some technical pearls: I think you have to choose your laminoplasty patients wisely. I think you have to look at their alignment preoperatively. I think you have to have a meticulous dissection. Try to avoid lifting C3 if possible. Maybe do a partial C3 laminectomy or a complete C3 laminectomy if needed for the decompression. A meticulous closure, and really I treat patients no collar and aggressive PT program very quickly post-operatively. Just a couple intra-op photos here showing them maintenance of the muscle attachments on the C2, lifting laminoplasty plates, trying to keep these incisions relatively small, really good muscle closure, and then fascial closure. So again, I'll kind of leave you with, I think the 3 most important things to think about are preoperative alignment considerations, intraoperative considerations, and post-op rehab. And I think we're going to learn a lot more about this kind of in the future. So again, thanks so much for the opportunity to participate, and I'm happy to answer any questions.